Bismillahirrahmanirrahim. My name is Dr. Humaira Mustafa, and today I am presenting the management of pediatric oncological emergencies. I have no disclosure to make. My objective of presentation is initial evaluation and stabilization steps in a oncological patient presenting with acute emergencies. Pediatric oncological patient may present a variety of life-threatening situations. It may be functional compromise of cardiopulmonary and neurological systems, or it could be hematological abnormalities like hyperleukocytosis, bleeding, DIC. These patients are immunocompromised and they have weak immune system, so they are high risk of life-threatening infections. So they can present with life-threatening infections. These emergencies may occur as a result of disease itself or as a consequences of treatment as these patients receive immunosuppressive drugs. These events can occur anytime from the initial diagnosis of cancer to the end-stage disease. So multidisciplinary approach is essential in achieving the optimal outcome. Prompt recognition and appropriate management is a key of management to decrease the morbidity and mortality. We can broadly categorize the oncological emergencies into 4 types. It could be metabolic abnormalities like tumor lysis syndrome. We will discuss it in detail later on. It could be hypercalcemia of malignancy. It's a paraneoplastic syndrome, the child usually with the bone metastasis or with the parathyroid hormone releasing protein. As are the metabolic abnormalities, the child could be presented with the SIDH, usually the child with head and neck and brain tumors present with the syndrome of inappropriate ADH secretion. Other presentation of oncological emergencies could be hematological abnormality like hyperleukocytosis. If the TLC count is more than 100,000, the child can present with DIC, thrombosis and bleeding. The child can present with infectious emergencies with febrile neutropenia, neutropenic colitis, septic shock and hemorrhagic cystitis. The oncological patient can present with the mechanical emergencies with the superior mediastinal or superior vena cava syndrome, spinal cord compression, malignant cardiac tamponade or increased ICP. There is a list of serious complication or emergency presentation of oncological patient. Here we will discuss the 4 most common conditions which should be identified promptly and treated. We will discuss tumor lysis syndrome, febrile neutropenia, anterior mediastinal mass associated emergency and spinal cord compression with the case scenarios. So our case 1, here is a child, 10-year-old, previously healthy girl presented to emergency department with fever for 10 days, decreased urine output for 1 day and generalized body edema. The patient is lethargic but oriented and have tachypnea and PTP. Her lab workup showed hemoglobin is 5.2, WBC is 250,000, platelet is 32,000 with peripheral film of 35% blast. Her biochemistry shows lactate dehydrogenase is elevated, uric acid is 13, which is high potassium and increased phosphorus with the low calcium, and creatinine is 1.5. This child is potentially a case of oncological emergency, oncological patient with potential leukemia, as the child has raised TLC count and having blast, and the child is in biochemical laboratory TLS as well as clinical TLS, as the child has clinical symptoms of decreased urine output and generalized body edema. So the diagnosis, what is the most likely diagnosis, is a tumor lysis syndrome, which is the most common disease-related oncological emergency. It has a high risk of morbidity and mortality if not identified and treated promptly. So what is tumor lysis syndrome? In the oncological patient, the cancer cell destroyed and release the intracellular content into the blood, which lead to hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia secondary to hyperphosphatemia. And these metabolic problems, these metabolic syndromes lead to clinical complication with the child presented with acute kidney injury, cardiac arrhythmias, seizures, or even death can occur as a result of these disturbances. So in our scenario, the child presents with the metabolic derangement and with decreased urine output. So the child has in clinical TLS and laboratory TLS. We will discuss later what is laboratory and clinical TLS. Here, point to remember, we should suspect the TLS with the triad of hyperuricemia, hyperkalemia, and hyperphosphatemia. Hypocalcemia is secondary to hyperphosphatemia. This is the Cryon-Bishop criteria for the definition of tumor lysis syndrome. We can classify the TLS as the laboratory TLS or the clinical TLS if the child has clinical symptoms. Laboratory TLS include if the child has at least 2 parameters within 24 hours, with the uric acid is more than 8, it is an adult value. In children, if it is more than upper limit of normal for age, or potassium is more than 6, or phosphate is more than 6.5, or if there is increase in 25% increase from the initial value, with the, or the child have hypocalcemia or the decrease in calcium 25% from the baseline, we can classify as laboratory TLS. And in clinical TLS, child has renal dysfunction, raised creatinine, decreased urine output, oliguric, less than 0.5 ml per kg per hour urine output in 6 hours, cardiac involvement, arrhythmia due to hyperkalemia and hypocalcemia. It could be neurological involvement, tetany and seizure because of hypocalcemia, or if the child die with the laboratory with above laboratory parameters, we then classify the child as a clinical TLS. So for the classification of clinical TLS, we need a laboratory TLS and one organ dysfunction, or if the child died. So who at risk? The child at risk. TLS can occur in any malignancy who have rapid turnover cells, or if the tumor burden is high, or if the tumor cell is highly chemosensitive. So it's mostly commonly occur in leukemia and high-grade Burkitt lymphomas. Solid tumor are at low risk. Pre-existing renal failure is an independent important risk factor for the tumor lysis syndrome. So TLS can occur. It is important to know that the child might be in TLS before the initiation of chemotherapy, or the TLS, the child may go into a TLS tumor lysis up to 1 week after the initiation of therapy. So screen for TLS at the time of presentation is important. So how do you confirm the child is in TLS? How do you diagnose? And how you will monitor the child with the tumor lysis syndrome? As we discussed, in tumor lysis, the malignant cell destroyed and rapidly turned off and release the intracellular content into the bloodstream, which lead to increased serum uric acid, increased serum phosphorus, and increase in serum potassium with decrease in calcium, or it increase the serum creatinine with the increased load to the kidney. As these metabolites release from the bloodstream into the bloodstream, the kidney is able to excrete out and values turns to the normal. But if the tumor burden is high, these values are sky high and they need to be treated. So which cancer at high risk, and how frequently you need to monitor. In high risk patient with a high TLC count or the LDH value is more than 2 times of normal, these patients at high risk, they need more frequent monitoring, 4 to 6 hourly. And if the LDH value is less than 2 times of normal and TLC count is low, you can monitor the patient 12 hourly. So what is the pathogenetic mechanism? What happened in the tumor lysis syndrome? Why these intracellular content damage the body? damage the kidney. Initially, the initial and most common abnormality is hyperuricemia. The uric acid load increased to the kidney, and uric acid crystallization lead to acute kidney injury, and these hyperuricemia and uric acid crystal further aggravate the precipitation of calcium and phosphate crystals. Hyperkalemia is more pronounced, and hyperphosphatemia is more pronounced in the patient who is having pre-existing kidney injury or who developed the AKI. So hyperkalemia present with paralysis, fatigue, arrhythmia, or death, and hyperphosphatemia and hypocalcemia is present. Then if the hyperphosphatemia is present, it will bind to the calcium and make the calcium phosphate crystal. So hypocalcemia is secondary to hyperphosphatemia, and hypocalcemia is, and this crystallization deposit into the kidney lead to further kidney damage, and these calcium phosphate crystals are deposited in the conductive system of heart, lead to conduction abnormalities and fatal arrhythmias. While hypocalcemia may become symptomatic, neuromuscular excitability, tetany, arrhythmia, bronchospasm can occur. If the child is symptomatic, hypocalcemia need to be treated. Otherwise, no need to treat hypocalcemia in case of tumor lysis syndrome. So, how do you manage the child who presented to you with the tumor lysis syndrome? It needs a multidisciplinary team involvement. Oncologists, nephrologists, and critical care physician should be involved in care of patient with tumor lysis syndrome. The best treatment is aggressive hydration with 125 ml per meter square per hour, and this aggressive hydration flush out these intracellular content out from the body. The preferred isotonic fluid solution, isotonic fluid is the standard fluid to be used with no potassium, and aim is to prevent the uric acid crystallization and calcium phosphate deposition in renal tubules. Urine output of the child should be monitored hourly and should be over 3 ml per kg per hour. There is no role of diuretic in tumor lysis syndrome, but if the child is symptomatic hypovolemic, then in case of need, use loop diuretic, and thiazide diuretic are contraindicated because it further increases the level of uric acid. In the past, urine alkalinization was used to favor the conversion of uric acid to urate and decrease the uric acid crystallization in the kidney and decrease the renal damage. But on the other part, these urine alkalization causes aggravation or further precipitate the calcium phosphate crystallization into the renal tubules and causes damage. And this, the use of alkalosis by carb, it decrease the amount of urine serum alkalinization leads to decrease the ionized calcium in the serum by increased binding of calcium to the albumin, and it decreased ionized calcium, free calcium leads to fevers, arrhythmia and tetany, and the child becomes symptomatic. Therefore, urine alkalinization is no longer recommended nowadays. So what is the treatment option for uric acid reducing agent? We are discussing the hyperuricemia, tumor lysis syndrome, and three main problem is hyperuricemia, hyperkalemia and hyperphosphatemia, and now we are discussing the management option. Initial treatment should be hyperhydration, and it should be multidisciplinary team involvement for the tumor lysis management. So uric acid reducing agent which are used is allopurinol and febuxostate. They are xanthine oxidase inhibitor, and they inhibit the conversion of intracellular content of nucleic acid to xanthine. Nucleic acid is converted to xanthine, and hypoxanthine and hypoxanthine will convert it to xanthine and then uric acid. So xanthine oxidase inhibitor inhibit the conversion of xanthine to uric acid, but allopurinol and febuxostate has no effect on the uric acid that has been already been formed. So the beauty of febuxostate is that it has no hypersensitivity reaction like the allopurinol have, and it does not require dose adjustment if the patient develop has decreased urine output or has decreased glomerular filtration rate. While their new promising therapy, which is very beautiful drug and is a respiratory, is a recombinant urate oxidase which convert the uric acid into more soluble form, which can easily be washed out from the body, and it clear out the uric acid from the body. So, urate oxidase recombinant respirase convert the uric acid to allantoin, and it's excreted out from the body. It's water soluble, but before prescribing the respirase, it needs the testing of G6PD enzymes level, because if the patient is G6PD deficient, the respirase treatment, the child may develop hemolytic anemia, will develop the hemolytic anemia, and can develop the methemoglobinemia in patient with cytochrome B5 reductase or other antioxidant enzyme deficiencies. So, as we talk about with the tumor lysis, when the cell break down, nucleic acid content released into the bloodstream, and then nucleic acid converted into purine to hypoxanthine and xanthine, and this xanthine is converted to uric acid, and this uric acid lead to damage to the kidney because of increased concentration. So these uric acid will precipitate into the renal tubules. So allopurinol and febuxostate is a xanthine oxidase inhibitors. They inhibit the conversion of hypoxanthine to xanthine and xanthine to uric acid, but it does not work on already formed uric acid. But as we have discussed, resveratrol's is a recombinant urate oxidase, and it converts the conversion of uric acid to allantoin. So in what patient we prescribe the resveratrol's? If there is a too high tumor burden and the child has a high uric acid level, and we are considering the child is in the high tumor burden, and a child has a high tumor burden, so like in Burkitt lymphoma and high hyperleukocytosis, so we usually prescribe the resveratrol's. And if the initial level is, if the levels are in increasing trend, so we prefer the resveratrol's in those patients. So second metabolic abnormality in the tumor lysis syndrome is hyperkalemia, which should be promptly treated and identified, otherwise it leads to life-threatening arrhythmia. And the continuous ECG monitoring is required for the identification of tall T wave, wide QRS complexes, prolonged PR interval, and flat P wave. So what is the goal of hyperkalemia management? The three main goals is myocardium protection, and with the calcium chloride, it stabilizes the myocardium and antagonize the membrane action of hyperkalemia. We prefer calcium chloride, and for intracellular shifting of potassium, we use insulin and glucose and bicarb and albuterol. They shift the potassium into the cell, but the bicarb is not recommended, as we have discussed in tumor lysis syndrome, except in selected cases when the child has in severe metabolic acidosis and have cardiac dysfunction. The third goal is excrete out the potassium from the body. Our first goal is to stabilize the myocardium. The second goal is shifting of potassium inside the cell, and our definitive goal is the excrete out the potassium from the body. So we use sodium polystyrene sulfonate, but it can lead to hyponatremia and Lysis, which increase the potassium excretion in urine. And the third, dialysis also excrete out the potassium from the body, but it required in those cases that the child developed the acute kidney injury. And the potassium, there is an indication of dialysis, we will discuss later on. So for the treatment of the third metabolic abnormality is hyperphosphatemia and tumor lysis syndrome. So main management is volume expansion with isotonic fluid, dietary restriction, oral phosphate chelating agent with calcium acetate, sevelamer, and mucin syrup contain ammonium hydroxide and magnesium hydroxide. Dialysis is indicated when the calcium phosphate byproduct exceeds the 70 mg per deciliter square, despite the therapeutic and prophylaxis measures are failed. So calcium supplementation is not routinely recommended, and we just treat the hypocalcemia only on those patients who develop the severe symptom of hypocalcemia in the form of tetany, Chopstick sign, muscle fasciculation, laryngospasm, or arrhythmias. Our goal is to elevate the symptom, not to normalize the hypocalcemia. So, what is the role of chemotherapy moderation in the prevention of tumor lysis syndrome? As we discussed, some tumors are highly chemosensitive, and when we start the chemotherapy, the child goes into the tumor lysis syndrome. So, we can discuss the case with our oncologist to start with less aggressive chemotherapy regime in order to slowly reduce the tumor burden and allow enough time for the compensatory kidney function to remove the products from the tumor lysis. For those, for dialysis indication in case of tumor lysis are if the potassium has more than 6 and phosphorus is more than 10, and the child has rising creatinine level with falling urine output, and the child is symptomatic hypocalcemia, fluid overload, and uremia. So AKI is the most important predictor of short and long-term mortality in tumor lysis. And what type of dialysis is indicated in case of tumor lysis? What are the options are best if the child presents with tumor lysis? The best modality of management in case of tumor lysis is hemodialysis or continuous renal replacement therapy. Peritoneal dialysis is not adequate for the in case of tumor lysis syndrome. And for how long renal replacement therapy should continue? It continues until the urine output and electrolyte value returns to normal, and it's important to avoid and stop all nephrotoxic drugs. So here are some summary points regarding the tumor lysis syndrome. So tumor lysis is a metabolic syndrome characterized by hyperuricemia, hyperkalemia, and hyperphosphatemia, and it is not always chemotherapy induced. It can occur before starting chemotherapy, it can occur spontaneously. It's a life-threatening complication, so it should be timely identified and treatment is required. Is the key of timely identification and treatment, and prompt treatment is the key of success of treatment. So prevention and treatment of TLS is required. The awareness of its cause, its physiological consequences we should know, and what are the predisposing risk factors. The child has decreased urine output, as we have discussed in our case. The child is at high risk of tumor lysis, and appropriate implementation of appropriate prophylactic measure with proper hydration, vigilant monitoring of electrolyte level in patient undergo chemotherapy is mandatory. Now going to our second case, 6-year-old girl with acute lymphoblastic leukemia who received the maintenance chemotherapy 10 days ago, present to the emergency department with a 24-hour history of temperature of 38.5 with cough and malaise. Hemoglobin is 7, WBC count is 1.2, platelet is 14,000, and neutrophil is 2%. The child is immunocompromised and recently received chemotherapy. The child has fever and her absolute neutrophil count is less than 500, is about 240. So the child is fever with the immunocompromised state. We will label the child as having febrile neutropenia. So what is febrile neutropenia? Fever in the presence of neutropenia is a common condition, is a medical emergency, and prompt treatment is required to improve the outcome. Any oncological patient who have a fever of 38.3 single spike, or if the temperature of 38 degrees Celsius for more than 1 hour, we will take it serious. We should take it serious. And if the ANC count is less than 500, or if the ANC count is less than 1000 and there is expected decline of to less than 500 in next 2 to 3 days, we should label this child as a febrile neutropenia. Here is a very important neutrophils. What is neutrophil? How the neutrophil help in our body defense system. The neutrophil is our major defense organ in the body against infection. It engulfs the microbes, it excretes the reactive oxygen species, it produces various antimicrobial mediators, and it destroys the pathogen. What happens in an oncological patient? The neutrophils, they have immunocompromised state, they have low and decreased function, low number and function of immune cells. So they are at high risk of developing of bacteremia, septic shock, and multi-organ failure. Neutrophils is also generate the release the endogenous pyrogen. So what happens in other oncological neutropenic patient? They are neutropenic and they are unable to generate the inflammatory response as our immunocompetent host does. So what happens? They do not exhibit the sign and symptom of severe infection, and single spike of fever is important in these neutropenic patient, because if they are not timely identified, they lead to septic shock and multi-organ dysfunctions. So they are at high risk of infections. The child who are at risk for febrile neutropenia, the patient receiving chemotherapy for ALL and AML, the child receiving intensive chemotherapy for solid tumors, and those on myeloablative conditioning therapy for hematopoietic stem cell transplant. These patients are at very high risk for febrile neutropenia. Neutropenic patients are at risk for both common opportunistic infection. They are at risk for both gram-positive and gram-negative organism infections. If the febrile neutropenia is prolonged, there is high risk of fungal infection, and viral infection should also be considered in these neutropenic patients. So how do you investigate? The diagnosis of febrile neutropenia is both clinical and on laboratory ground. There must be a fever and low ANC. The important history point we should ask, or we should identify when we are dealing with the pediatric oncological patient with fever. We should ask about type and duration of recent chemotherapy. What is the localizing symptom? Ask, are there any localizing symptoms? Any skin breakdown? And is there any contact history in the family? Or ask about any underlying comorbid condition. If the child is receiving any immunosuppressive drug, because in case of infection, these immunosuppressive drugs need to be stopped after consultation with the pediatric oncologist. So document the presence of central venous catheter, which may be the source of infection, and also check previous microbiological confirmed diagnosis and pattern of resistance if available. So the child present to you with febrile neutropenia, it required thorough clinical examination other than vital sign, oxygen saturation, then check the skin for any local skin breakdown, any abscess, cellulitis, check the oral cavity for mucositis, candidiasis, do the ENT examination, upper respiratory tract infection for sinusitis, otitis media, because these minor infection can lead to life-threatening infection. So these infections should be identified early. Do the respiratory, CVS and abdominal examination, and also check the central venous sites for erythema, swelling, tenderness, tracking along the line site. The lab required is CBC, basic lab workup, CBC electrolyte, blood urine nitration cracked, take the blood culture and send inflammatory markers, urine analysis for UTI. If any wound, take the swab culture, stool culture if the child present with diarrhea or abdominal distension, send Clostridium difficile toxin or PCR test, renal and liver function test, blood gas for venous lactate, complete viral respiratory panel, X-ray and high resolution CT to find out any invasive fungal infection, CT and brain and abdomen. So how will you manage in the pediatric oncological patient present with febrile neutropenia? It required the administration of broad spectrum antibiotic within 1 hour, because they have no time of spread of infection, easily spread off, and they can lead to life-threatening organ damage. So it required the early administration of broad spectrum antibiotic, which cover both the gram-positive and gram-negative infections. And if you are considering the fungal infection, give the antifungal and consider the viral antiviral agent when the situation warrants. These patients usually required PICU supportive care with the oxygenation, inotropes, fluid requirement, and consider the cardiac dysfunction if they required inotropes. And also be aware these children are at risk of adrenal suppression because they are on prolonged steroid therapy. So if the inotropes are not working, you should consider the stress dose of steroid in case of septic shock. These children may require colony stimulating factor if they are severely neutropenic and prolonged neutropenic, and you anticipate the bone marrow recovery is delayed and the child is having significant sepsis. And when to stop antibiotic, 10 to 14 days usual course, or till the ANC count is more than 500, or your clinical microbiological reports will decide about the duration of antibiotic. What is the prognosis of febrile neutropenia? Is depend upon the severity of disease and the organ system involvement. If it is picked early, treat early, there will be the chances of good prognosis. Or if they are not picked early, if they are picked early and delayed treatment lead to worse prognosis of febrile neutropenia, the child have cardiogenic dysfunction, septic shock, and multi-organ involvement. So here are the some summary point for the febrile neutropenia. Any oncological patient present with neutropenia and fever, consider the febrile neutropenia is a common condition, an important cause of morbidity and mortality in pediatric oncological patient. So prompt recognition and rapid intervention is a key of success, and it decreases the morbidity and mortality. Now come to the case 3. A 6-year-old boy came with a complaint of facial puffiness and a feeling of lethargy. He additionally reports shortness of breath and cough for last 15 days and difficult lying down for 2 days. On examination, the child is having respiratory distress in the form of suprasternal or intercostal recessions. There is facial edema, prominent vein detected in the upper chest, and chest X-rays ordered. Here the main point would be symptom the child has is difficulty in lying down for last 2 days, and there is facial puffiness. So chest X-ray order, which shows the widening, huge mediastinal widening and loss of airway shadowing on the left side of lung. When the subsequent CT was revealed, there is a mediastinal mass compressing the trachea at the level of carina. So the child has the anterior mediastinal mass which compresses the trachea, and the superior vena cava lead to superior mediastinal mass syndrome and superior vena cava syndrome. The child present with dyspnea because of superior mediastinal mass, and because of because of superior vena cava obstruction, the child has edema over face and there is an engorgement of veins. So the child is previously asymptomatic, and it is a possibility the child is previously asymptomatic and then may develop catastrophic airway collapse and cardiovascular compromise. So management is challenging in these cases if the child have anterior mediastinal mass. Commonly, our mediastinum is a narrow closed space, and if there is any mass in the mediastinum, it will if there is any growing mass into the mediastinum, it will compress the adjacent structures. Like we divide the mediastinum into anterior, superior, middle, and posterior mediastinum. The masses which usually lymphomas are present in the anterior and middle mediastinum and causes compression of trachea and the great vessels, while the posterior mediastinal masses are neuroblastoma and neurogenic tumors. The child with anterior mediastinal mass can also present with hematological effect, with hyperleukocytosis, cytopenias. They can be present with tumor lysis syndrome, and they cause compression. They can present with a local compressive effect like superior vena cava syndrome. As we know, the superior vena cava is thin-walled and easily compressible. If there is a mass in the mediastinum, it will compress the superior vena cava and cause superior vena cava syndrome and decrease the preload towards the heart. And the mediastinal mass in the anterior mediastinum can also compress the trachea. Anterior and middle mediastinal mass can also compress the trachea, brain, main stem bronchi, or pulmonary compression lead to superior mediastinal mass syndrome. The child can also present with pleural pericardial effusion, or they can also be presented with cardiac tamponade. The two entity of superior vena cava and mediastinum is life-threatening, and we should consider the child has difficulty in breathing or lying down position, and having breathing difficulty in lying down position. So we should consider the anterior mediastinal mass which causes compression. So here is the CT images, and there is a superior mediastinal mass which causes compression of the superior vena cava. Is narrow, occluded. In the children, the airway is highly compliant, so trachea is also compressed and causing symptoms, while the normal CT mediastinum shows the well-identified superior vena cava, and you can see here the trachea normally. The patient with non-Hodgkin lymphomas their first manifestation could be massive pericardial or pleural effusion. So we should consider the lymphomas in our differential if the child presenting with the pericardial pleural effusions. So what are the usual signs and symptoms of the child with mediastinal mass? The child can present with respiratory complaints, like our child in our scenario present with difficulty in breathing and orthopnea. So they can also present with pleuritic chest pain and wheezing. There could be distension of veins, edema of the face and upper extremities. Children with superior mediastinal mass and superior vena cava syndrome may be asymptomatic at the presentation, and they can present with catastrophic condition with cardiopulmonary collapse. So orthopnea is the symptom we need to ask in the history, as it is the possibility that the parents may not give you the information about it until you ask. So what is the diagnostic approach in case of anterior mediastinal mass? There we go for the radiological testing. We can get a blood test for SVC, peripheral smear, tumor lysis marker, lactate dehydrogenase level, and tumor markers. And the diagnostic test can be flow cytometry, non-invasively, blood, bone marrow, pleural and pericardial flow cytometry, or biopsies of lymph node and mediastinal mass. The child establishing a diagnosis in a child with anterior mediastinal mass may be impossible in certain cases if the child has exhibit the respiratory distress, is in severe distress, and is unable to be lie down. And we should not be forced the child to lie down, as total airway loss may be precipitated by simply placing the child in the supine and flex position. So use of procedure and sedation and general anesthesia should be avoided, and we should involve the general anesthesia team and CTS for if the airway is compromised, and the child should be intubated in the OR if required. So, point to be remembered, during the process of establishing a diagnosis, care must be taken to protect the airway and avoid a cardiovascular collapse. Golden rule is to establish the diagnosis in a case with anterior mediastinal mass. Start with the less invasive procedures like flow cytometry of blood, pericardial and pleural fluid, and lymph node biopsies in case of lymphadenopathy. So, management option of for the life-threatening situation: keep the patient upright position, give oxygen inhalation, and if the child has pleural effusion and pericardial effusion, place the pigtail or chest drain and give the empirical chemotherapy to relieve the symptoms, or surgical resection may be required if the child is resistant to chemotherapy. Empirical chemotherapy, in most of the cases, corticosteroid therapy provides significant tumor reduction, but it should be started with the consultation of the pediatric oncology team. Sometimes these tumors are resistant to steroid and they need the radiation therapy for emergent radiation therapy to relieve the symptoms. So, if the child with anterior mediastinal mass, the intubation is very high risk. There is a high risk of intubation. So, multidisciplinary approach, the cardiothoracic surgeon, anesthesia, intensivist should be involved in the management of the child with anterior mediastinal mass, and this intubation should be done in more controlled environment like in OR, and the intubation should be done with topical anesthesia and under light sedation, and we should avoid the neuromuscular blocking agent, as the neuromuscular blocking agent decrease the transpleural pressure gradient to prevent the descent of diaphragm, and it augment the extensive compression effect of the mass. The tube size is important when we are considering the intubation of anterior mediastinal mass. The endotracheal tube size should be with the decreased diameter, but the length should be sufficient to bypass the compression. Flexible or fiber optic bronchoscopy or ECMO support should be available, should be considered in cases of in advanced cases, but unfortunately ECMO support is not available in our system. So, key learning point of the child, the key summary points of our child presented with anterior mediastinal mass. Child may present with life-threatening respiratory emergency, hemodynamic instability. There is a high risk of collapse when we are using a sedative or anesthetic agent in these patients. So, management is challenging and require different approach than routine usual care of the children. So, our fourth case is 6-year-old child present with backache and lower limb weakness for 1 week, also associated with urinary and fecal incontinence. He was diagnosed to have neuroblastoma 3 months back. On physical examination, the child has tenderness on percussion on the back, decreased strength and hyporeflexia on the right lower extremity, poor sphincter tone or rectal examination. So, he is the known case of neuroblastoma. We should consider the spinal cord compression if the child present with a backache and lower limb weakness, and it can be present at the time of presentation or later on with the progression of tumor. So, in one study, it showed that spinal cord compression occurred approximately 5% of our pediatric oncological patients. Early recognition and treatment is essential. If not detected timely, it will lead to irreversible damage or permanent paralysis. So, always consider the spinal cord compression in a child present with backache and suggestive neurological finding. Who are at risk? Any type of tumor, but mostly neuroblastoma, sarcoma, leukemia, metastatic brain tumors present with the spinal cord compression. So, the spinal cord compression can occur by direct tumor extension or by intradural metastasis or bony metastasis, lead to crush fractures and causes spinal cord compression. They usually clinically present with back pain, and these back pain symptom is usually missed and it will later lead to permanent damage. So never ignore the back pain in a child, in oncological patient present with the back pain. Suspect spinal cord compression when the back pain is not relieved by supine position. Or it can present with a motor or sensory weaknesses. The child can present with paraplegia, quadriplegia, or sphincter and incontinence. So depending on the rate of tumor growth, it can be present at the time of presentation, or it can be acute presentation, or it slowly, if the slowly progressive tumor, the child can later present with weeks to month of diagnosis with the spinal cord compression. Tenderness to palpate, we should palpate the patient to localize the site of lesion and do the neurological examination. Never, point to remember here is never ignore complaint of backache in child with oncological disease. So how do you diagnose a child with the spinal cord compression? CT has no role, and the MRI is the gold standard for the diagnosis of with or without gadolinium enhancement for the diagnosis of spinal cord compression, or any further diagnosis of mass which causes the compression of spinal cord. So if in rare cases when the MRI cannot be performed, the CT myelography is an acceptable alternative. How do you manage when you are dealing with a child with the spinal cord compression, you first think about what is the cause and what is the underlying cause and what is the treatment trajectory should be. So initially we give the supportive management with analgesia, opioids and neuropathic medications, laxative to relieve the constipation. We can start dexamethasone with dose 1 to 2 mg per kg IV. We should involve the multidisciplinary team if we are dealing with a child with spinal cord compression. We involve pediatric oncologists, radiation oncologist and neurosurgery team. If the rapidly expanding mass, emergent laminectomy may be required with posterior decompression. Radiation therapy or chemotherapy may be will required as per the diagnosis of underlying malignancy. So what is the prognosis? The key of the prognosis basically depend upon when you pick the child or how long the child had these symptoms. A duration of symptom is important, and at the time of presentation how much the child had neurological deficit. If neurological deficit is for a long time, it will be irreversible damage. So and it will require the palliative therapy for the positive impact on quality of life. So the key learning point here, back pain in a child with a history of cancer should raise the suspicion of malignant spinal cord compression. Therapy initiation as soon as the diagnosis is considered may improve the prognosis. Recovery depends upon the status or the time of diagnosis, progression of symptoms, underlying cause, malignancy, which is chemo-sensitive or radiation-sensitive, depend upon the nature of malignancy and the timely intervention of definitive therapy. Thank you.